Casestudy4a Endocrine by Erin Amorosi and Lisa Llewellyn. You've been notified that you are receiving a new patient from the emergency department. Patient name Ronald McDonald, 56-year-old Caucasian male, weight 225 pounds and height is 5'7". His chief complaint has been nausea and vomiting and general malaise times 4 days. Recently, he was experiencing cough and fevers. Past medical history includes hypertension, hyperlipidemia, GERD, type 2 diabetes, CVA, neuropathy, and obesity. Social history: he is a current smoker of 27 years and an occasional drinker. Family history: father is a type 2 diabetic and had a CVA in the past. Mother had breast cancer and hypertension. Maternal grandfather has a history of colon cancer. Mr. McDonald has allergies to sulfa and latex, and current medications include insulin glargine, metformin, lisinopril, atorvastatin, gabapentin, and omeprazole.
All right, Mr. McDonald's arrived in the ICU and you're starting your assessment. He's noted to be lethargic with dry mucous membranes and tenting skin. His skin is cool and clammy. On the monitor, you notice tachycardia, hypotension. The EKG reads sinus tach. He says he did not take his blood pressure meds today because he felt sick and was vomiting. You notice that his breathing is deep and labored and rapid. His chest x-ray was negative. He denies feeling short of breath. He was noted to have several episodes of emesis in the emergency department, and he has a poor appetite right now. You did get an antiemetic ordered, and he also voided 480 cc's of yellow urine, which was sent to the lab. Here are Mr. McDonald's vital signs. Take note of when he arrived. He was febrile, hypotensive, tachycardic, satting 93% on room air with a respiratory rate of 38. Once he arrived, we sent off labs, cultures, gave an antipyretic, and you can see the difference that IV fluids and those interventions are making. Wow, look at these lab results.
With all of the above information, vital signs, lab work, and patient's complaints and symptoms, what is the diagnosis?
Great job. You were right. The diagnosis is diabetic ketoacidosis, or DKA. DKA is a life-threatening complication of usually type 1 diabetes, but can also occur in type 2. And in DKA, you see hyperglycemia, ketoacidosis, and ketonuria. This happens because there's not enough insulin to utilize glucose for metabolic fuel. This insufficiency leads to the accelerated release of counter-regulatory hormones such as glucagon, catecholamines, cortisol, and growth hormone, which in turn actually make your blood sugar higher and make the situation worse. This hypercatabolic state leads to the breakdown of fat. The byproduct of this fat breakdown is ketones, which is an acid and therefore causes ketoacidosis.
Some causes of diabetic ketoacidosis can be insufficient insulin, recent acute illness or acute infection, lack of access to insulin, non-compliance to medication, or a new diagnosis of type 1 diabetes.
Symptoms of DKA are decreased level of consciousness and confusion, blurred vision, seizures, headache, Kussmaul's respirations, fruity smelling breath, dehydration as evidenced by dry skin and mucous membranes, flushed face, polyuria, polydipsia, polyphagia, muscle aches or stiffness, nausea, vomiting, abdominal pain, gastroparesis, tachycardia, hypotension.
Relevant lab findings that you will see in patients in diabetic ketoacidosis include a pH less than 7.3, a CO2 less than 15, a high blood glucose, a high sodium, high potassium, an anion gap greater than 10, a serum bicarb that is low, urine with positive ketones and glucose, a serum beta hydroxybutyrate greater than 40, and a high serum osmolarity.
Treatment for DKA is aimed at correcting the acidosis, correcting the dehydration, and correcting the electrolytes. So one of the first things you want to do is get your baseline labs, IV fluids, give insulin, and with insulin administration, you must replenish the potassium. The insulin pulls potassium into the cells, so you'll wind up with hypokalemia. A lot of times the patients need to be placed on an insulin drip and sent to the ICU for close monitoring. You also need serial labs to trend the anion gap and monitor those electrolytes. And you will also monitor the blood glucose, usually hourly while they're on the insulin drip. Enjoy this picture that we created that shows the potassium and hydrogen exchange between the intra and extracellular fluid. Maintain the patient's potassium. During the early phase of DKA, your patient might be hyperkalemic, but once your insulin infusion is initiated, the insulin will pull potassium as well as glucose back into the cell. This will cause your patient to go hypokalemic, which is dangerous for cardiac arrhythmias.
Some other ways to manage diabetes and DKA would be to track your carb intake and monitor blood sugars, reaching out and establishing a rapport with a nutritionist or diabetic educator, continuous glucose monitors and or insulin pumps, daily exercise, emotional support, case management, and getting involved in support groups.